recently completed my interventional cardiology fellowship at the Minneapolis Heart Institute and Hennepin County Medical Center in Minneapolis, and this was one of the cases during my fellowship. So the title of my case is Use of CTO PCI Technique for Salvage. So the case is of an 83-year-old female, and she had all the risk factors for coronary artery disease and also had CKD stage 3, presented to our hospital with worsening dyspnea, no real chest pain as such, mild troponin elevation, and her echo showed an inferior wall motion abnormality and an ejection fraction of 40 to 45%. So her initial angiogram was done right radial, thought to be potentially something straightforward. So this is the right coronary artery. I'll try to plate again here. And if you can appreciate there's a little bit of overlap, but there's a very tight, tortuous, potentially calcified lesion in the mid-RCA there, which obviously looks like the culprit. This is an RAO view there, lays it out a little bit better. Again, you can see the tortuosity there. Definitely very tight lesion. Difficult to appreciate how calcified it is there, but the initial, and so this is the injection of the left coronary system on the initial angiogram, and you can see that there's actually collaterals that are filling the right PDA and the PLV branches there because of that subtotal occlusion. So the initial PCI was attempted at that time from the right radial approach. Different wires were tried, and a run through a Fielder FC, a whisper wire, and then a Pilot 150 supported with a microcatheter was also tried. But what essentially happened was that the wires tended to go subintimal, and because of that, essentially ended up with a dissection and acute vessel closure at this point, as you can see quite clearly here. So at this point, luckily the patient was chest pain free. She never actually had chest pain even to begin with. We thought that her dyspnea was her anginal equivalent. So at this point, there was discussion among a couple of different operators about what we should do here. She did have a CKD stage 3 as well, and we had used some contrast already. And so we decided to abort the procedure here at this point, given that she was also fairly stable symptomatically and hemodynamically. And we thought that we should bring her back and try and use a CTO PCI technique, given that we had seen collaterals going from the left and filling retrogradely and filling the branches of the right coronary artery. So we brought her back. This is her dual injection, as you can see here. So the flow on the right side is a little bit better now. It's recanalized a little bit, but there is still collateral filling, and we thought that there were perhaps a couple of septals that were still supplying good collaterals. So we initially tried an AL1 guide catheter for the right coronary, but it actually didn't fit very well, so we ended up having to use a GR4 for the right and an EBU375 guide catheter for the left. So we initially thought, okay, maybe we can give it another try, antegrade. Sometimes you can form a little microchannel or something like that. And so we tried a Samurai RC and then a Fielder FC guide wire antegrade with a Mamba microcatheter, but ended up with essentially the same problem. It kept going subintimal. So we said, okay, I think we've had enough of this, and really going by the hybrid algorithm, although it is not technically a CTO case, we should switch strategy and go retrograde. So we advanced a Samurai RC guide wire down into the LAD. We usually try to keep a guide wire in the LAD as well, even while we're crossing into the septals, just in case something happens to the donor vessel there. So as you can see, so there's guide wire there, and then we had another Samurai RC with a Mamba microcatheter. We went into the first septal and did a microinjection there, and didn't really see a great connection from that one. So we switched to another septal. And here we thought that there was a good connection. We did septal surfing. We did use a Scion wire here, and with surfing, and then we were able to cross this second septal collateral and all the way and went into the distal RCA. The Mamba microcatheter would not cross the septal, so we switched to a Caravel because of its lower profile, and it tends to do better with small and tortuous collaterals. So the Caravel was able to make its way through to the distal RCA. So now that our retrograde wire was there, we thought, okay, let's try a wire escalation technique initially. But again, even though the lesion and the subtotal occlusion was fairly short, again, our wire continued to go subintimal, and we really were not successful. So at this point, we have our antegrade wire that to the point of occlusion, and you can see our retrograde wire is still clearly subintimal and not really tracking in with the true lumen that the antegrade wire is in, or that we thought it was in. So at this point, really what we did was we decided to perform a guideliner-assisted reverse cart. So as my previous presenter mentioned, this is a two-handed reverse cart. So what we basically have is it's an 8 French guideliner, and we switched for a pilot 200 guide wire retrograde. Initially, we used a 3.0 and then a 3.5 balloon, and really what we were using was called the draft technique, and I'll show this here, which stands for deflate, retract, and advance into the fenestration technique, in which one operator is able to inflate and then deflate and retract the balloon over the antegrade wire, while the other operator can simultaneously, while you're retracting your balloon over the antegrade wire, push the retrograde wire hopefully into this space and hope that it tracks from the subintimal space into the true lumen. So as you can see here, that's what we were attempting to do. So when we were not really being successful with the 3.035 balloon, we did IVUS at this point to see exactly what was going on here. And what it showed us was, one, it showed us where the wires were. It showed us that the antegrade wire was in the true lumen and the retrograde wire was subintimal. But the size of the RCA was larger than we thought, and it was more of a 4.0 vessel. And so we used a 4.0 balloon and decided to repeat the maneuver here. And as you can see here, there's a sort of a long fluorostore there, but right there, as you can see, the wire eventually did track the balloon into the guide liner there. And after that, we were able to advance our microcatheter retrograde into the guide liner and into the guide. We swapped that out for a R350 externalization wire, and over that, we were able to deploy 2 stents there. One long one, and we had to do one shorter one there, and it really got an excellent result at the end. So the take-home messages from this case, one is that PCI of complex lesions can always be complicated by acute vessel closure due to dissection. It's always a risk and can be catastrophic. Luckily, in our case, it was fairly well tolerated by the patient. If good collaterals are available, you can try and use retrograde CTO PCI techniques for bailout in these cases. Thank you.
Very quickly, in the interest of time, any comments?
Very nice, Arslan. I completely agree with this draft technique. I've been in a number of cases that you're like 20, 30 minutes, you're trying ballooning, trying, do the draft, the cart, and essentially as you do the draft, I think it's very nice cartoons. I think it's Carlino and Colombo a number of years ago had the technique you just balloon and essentially will suck down the wire into the guide catheter retrograde. It's a beautiful, very nice case.
Yeah, no, I agree. I think it does. The few times that I've used it or scrubbed into those cases, yeah, I think it works. I think it works well because I think it helps track the wire, sort of, like you said, sucks it in that way, and it worked. And I think the other thing that commonly happens is that you tend to undersize your balloon when you're doing a reverse cart, and so I think an appropriately sized balloon also helps with it. If it's undersized, I think you can keep trying over and over and it won't work.
Very good. Yeah, please. Next case will be Dr. Azam again. Is that correct? Successful removal